Let us welcome Professor Dr. Carlos Mena. He is our colleague from the USA working in Yale New Haven Hospital. Welcome, Doctor.
Good morning. Thank you very much to the organizers of the meeting for the opportunity to talk and present some of the data that we have collected. For full disclosure, I'm an investigator, member of many of the steering committees for both Lutonics and the COVID program, drug-eluting balloon programs in the United States. When we look at the treatment of peripheral vascular disease, I think that there is a big spectrum that starts with medical therapy and goes all the way to amputation, obviously a bad outcome and the one that have us here discussing all these different approaches. But the question is, where do new devices, new products fit in, and how can we deal with them as we collect clinical evidence to support the use of it? The problem is the pathway is very large, and the pathway starts with feasibility studies to the point where we can actually use them in clinical practice. And this slide is meant to show you what the pathway looks like, how many patients need to be enrolled, how much time, commitment, and resources have to be devoted to the development of this technology. When it comes to the use of drug-coated balloons, the ideal product should use the lowest dose needed to achieve a therapeutic tissue levels, very important. Retain drug on the balloon so that during the transit time, the medication is not lost. Ensure adequate drug transfer once the balloon is inflated. Produce an uniform, durable transfer efficient coating. And be able to demonstrate a histologic drug effect at least for 20 days post-treatment. And that could be achieved in many different ways. When you look at, specifically, I'm going to refer to the experience in the United States, the programs that we have available or we are conducting are the following. We have the COVID and drug-eluting or drug-coated series, and that involves the first Inman program, as well as European studies and the pivotal trial that is ongoing in the United States. And we're getting ready to launch the below-the-knee program. And then we have the Lutonics program by BART that has a SFA program below the knee, and we're about to start the in-stent restenosis program. So I'm going to try to divide this in two big aspects, the below the knee and the SFA, and show you what we think is the evidence. When it comes to below the knee, clearly the indication is critical limb ischemia, and that's what we care the most about. I think the story started roughly in 2011 with Dr. Smith's work and his registry, and I'll show a little bit of it in a second. And a lot of controversy has happened during the last few months, and many of it was shown at Link, for those of you that went in January, where the Medtronic data was presented that led to basically the withdrawal of the Medtronic products worldwide. So the initial experience, and I'll be curious to see what Dr. Smith has to say when we open it up for questions, started with his seminal work, was a single-center study where he was able to look about 104 patients. And basically what he tried to do is to determine the role of these devices in the treatment of patients with below-the-knee disease. The procedural methods are described in the slide. Inflation of about more than a minute. In case of more than 2 balloons, there was a significant overlap of those. Inflow disease was treated, and dual antiplatelet therapy was used. The patient population, most of them were critical limb ischemia. The mean lesion was about 17 centimeters, which is somewhat decent for patients with critical limb ischemia. Most of them were de novo lesions. And many patients had renal insufficiency, which will become relevant as we discuss the Medtronic data. As well, they had the usual comorbidities, including diabetes and smoking. The success rate was about 100%. There was about 5 bailout stents, which is remarkable given the nature of what these patients usually bring to the table. And the complications were not that significant. The 3-month follow-up showed that the angiographic follow-up, 72% of those patients were free from significant restenosis, and more than 61% of those restenosis, when did occur, were focal. The 3-month restenosis rate was considerably lower at that specific center compared to their controls. The amputation rate was about 4%, which was somewhat typical for the population that they treat or that we treat. This study was followed by an Italian study where it was also a single center, was a randomized controlled trial, however, where the key inclusion criteria were critical limb ischemia at least one tibial vessel runoff. The exclusion criteria listed there, the primary endpoint was binary restenosis at 1 year, and the secondary endpoint was a 12-month TLR and 12-month occlusion rate. This was somewhat of the flow of that specific study, and you see how DCB and standard balloon angioplasty was somewhat equivalent in terms of number of patients. The standard dual antiplatelet therapy was used, and adequate follow-up was guaranteed. In terms of demographics, it was pretty much the same. As you can see in the table, there's no significant difference in the p-value of any of them. The procedure characteristics were 100% were pre-dilated with drug-coated balloon. In other words, those patients were pre-dilated and then the drug-coated balloon was applied. The mean inflation time was about 140 seconds. Notice how the pattern here is that inflations are usually prolonged inflations, and that there was a very low rate of bailout stenting. The clinical outcomes showed that binary restenosis was significantly less in those patients that were in which drug-coated balloon was used. So was the target lesion revascularization. In addition to that, complete ulcer healing was significantly improved. Again, building momentum towards what we thought was going to be potentially the answer to the below-the-knee interventions. The author concluded that DCVs compared with plain balloon angioplasty had a strikingly reduced first-year restenosis with a target lesion revascularization and vessel occlusion that was significantly different compared to plain balloon angioplasty in patients with critical limb ischemia. The 2-year follow-up somewhat reinforced that message, and is seen in the slide here. But the problem with these studies, although clearly important because that's how the story begins, is that there were single-center studies and there are limitations that come with that. Especially there is lower external validity. There is a limitation in terms of the ability to generalize their data and their information. Some of them lack core lab and CEC adjudication, and they're good because they generate hypotheses, but they don't necessarily answer the specific clinical question. So that basically led us to the need for large, robust clinical trials, most of them randomized, that will hopefully answer the question. Professor Seller then embarked in Impact Deep, and I think that this is where the controversy started and calls into question what to do in the below-the-knee, specifically in critical limb ischemia. This was a prospective multi-center randomized controlled clinical trial, as good as it gets in our area. It was a rigorous executed study. There was an independent DCMB, CEC, as well as angiographic and core lab adjudication. The N was about 358 patients that were enrolled between September of 2009 and 2012. The primary effectiveness were angio cohort, late lumen loss at 12 months, as well as time of TLR, and in all patients, clinically driven TLR at 12 months. The primary safety endpoints at 6 months was all-cause mortality, major amputation, and clinically driven TLR. Very important because this is one of the main messages of this study. I'm not going to bore you with inclusion and exclusion criteria, but there are a few things that are important to highlight. Number one, they included Rutherford class 6, and also many of those patients had significant renal dysfunction. At least one non-occluded vessel with runoff to the foot, either direct or indirect collaterals. And then the exclusion criteria was basically planned for major limb amputation, inflow and/or inability to establish continuous inflow to the below-the-knee circulation. In-stent restenosis was also excluded. This is what the demographic looks like. In terms of age, gender, and risk factors, they were about the same. In the DCV cohort, as you can see, the patients were pretty much matched out in terms of Rutherford classification, most of them being Rutherford 5. There was a small number of Rutherford Cs and as well as Rutherford 4. The lesion characteristics between the two groups were very similar. As you can see, the impaired inflow was about the same in both groups. The degree of calcification was somewhat similar, and the target lesion in terms of length was pretty similar as well. The procedure characteristics, a few things to highlight. In the DCB, those patients, all those were pre-dilated compared to the PTA. In many of them, we just got one treatment was enough, and I would assume they were left alone. Inflation times is slightly higher in the DCB group, just to take that into consideration. The bailout stent was about the same. Complications about the same. Success rate and procedural success was equivalent. The primary outcomes, which is basically what we care about, in terms of 12-month late lumen loss, it was similar in both groups, as well as the clinically driven target lesion revascularization. But here comes the problem, the primary safety. 6-month death, major amputation, and clinically driven TLR. There is a trend in the DCV group for a higher incidence of these endpoints compared to the plain balloon angioplasty, which created a signal that called into question what we were going to do. The main issue here was that all of this was driven by the major amputation group. As you can see, it's not statistically significant, but there is a difference between the two groups and calls into question the safety of these devices. There are a lot of things that we can discuss during the Q&A session as to why this happened. But clearly it was the first randomized controlled clinical trial that basically highlighted that even though the initial studies were appealing, there is a lot of more things that we need to know about these devices, specifically as we apply them below the knee to be able to understand what their role is. And lastly, but not least, there is an NIH funding study that is a randomized controlled clinical trial of about 2,100 CLI patients, looking to what is the best strategy, surgical versus endovascular, and it's a 5-year follow-up. There's about 80 US centers and Canadian centers involved in this clinical trial, and the enrollment is slated to start very soon. I am not going to touch on the SFA right now because of the lack of time, but I will be happy to discuss this during the Q&A session. Thank you very much.
Thank you, Professor Carlos.